you for having me. This afternoon we will present our research on the longitudinal relationship between hearing aid use and cognitive function. As we agree that maintaining cognitive function in later life now has become a public health priority because the burden imposed by dementia has increased in this aging population and very sharply. For example, the disability adjusted life years per 100,000 population for dementia has grown for 43% over these 25 years, and the growth is more sharp, is very sharp in the Europe area. That's why then more and more study now looking at how to prevent dementia, and the work by Sergi and colleagues on the Lancet is the most crucial work, which mentioned that the midlife hearing loss is responsible for the 9% of the risk. Our research, prior research, which has been published in The Age and Aging, support this, and then we found that the people with the withdraw trajectories of cognitive function over years using longitudinal data in 3 areas. So we found that the respondents with poor hearing function, they have lower cognitive function than those without poor hearing function. So the red line is actually those with the poor hearing function, and then the black line is those with good hearing function. And we can see here that those with poor hearing function, they have a lower cognitive function over years, and the result is similar everywhere. So it is in the US and England, and then also in 9 countries in the Europe. So it is the similar result everywhere. And then the next question is, we know now that since hearing function and cognitive function are related, but how is the mechanism? So the studies has proposed 3 mechanisms. The first one is whether the cognitive function is actually lead to the hearing impairment, because listening is also cognitive task. To listen, we need cognition. We need to be able to receive the voice and then take out the noisy and everything else, and then this is a cognitive task. So it is possible that the cognitive decline is actually also affect the hearing impairment. And then the second mechanism is the sensory impairment. The hearing impairment leads to the cognitive impairment. So with the hearing impairment, it is only few stimulation on our hearing. If we less hearing, and then it could be that our cognitive is also affected. And then the third mechanism is while we're getting old, everything just decline. We got wrinkle, and then the hearing function decline, cognitive function decline at the same time, and then there is a third variable that cause all of this decline, because we know that some people aging faster than the other people. It could be for the vascular diseases, it could be also inflammation and other third common cause. So we want to know now which one is the mechanism, because it's crucial for us to decide or to create intervention. If the sensory hearing impairment leads to the cognitive decline, and then if we treat the hearing impairment, and then it will prevent us from the cognitive decline. To answer this question, and then we look at the longitudinal data. As others have mentioned, Helena and Sergi also, that the randomized control trial is still very rare, it's not still available, and then we need to use the available data. And then that's why then we use the longitudinal data. Longitudinal data is different from cross-sectional because it collects the data from the same person for many times. we know that in the cross-sectional data or in the epidemiological study, why we cannot say that it is causal effect, because some people will have variation with the other people, and we cannot control it like we do it in the randomized control trial. But using the longitudinal data, at least we can have like one step closer to the causal inference, because in this longitudinal data, this data allow us to follow one individual over time, and then we can then put an intervention over there, which is hearing aid use, and then look at the condition before they use hearing aids and the condition after they use hearing aids in the same person. By having this and the same person in our study, we hope that we can eliminate the between individual variation as minimized as possible, because we have the same person and then we follow it over years. This study already published in the Journal of American Geriatric Society, and then we want to look at the cognitive function before and after they first time use hearing aids. So we use the data from Health and Retirement Study Wave 3 in 1996 until Wave 12 in 2014. So Health and Retirement Study is longitudinal data which collected the data every 2 years. And we use the Wave 3, start from the Wave 3 because the Wave 3 is the one who has episodic memory measures available for every waves. So it's comparable. And then the inclusion criteria, this is also quite important for us, that the respondent should take part a minimum of 3 waves of the health retirement study. So we will eliminate those with only 2 times taking part of the study or only once, and then they have no hearing impairment and no dementia in the wave 3. And then the respondent also should use hearing aids between waves 4 and waves 11. By having this inclusion criteria, we expect to have for each individual, they will have at least 1 wave before firstly using hearing aids or 1 wave after they use hearing aids. So using hearing aids will be in the middle of the study at some point of time. We have the sample of 2,040 adults, and then we measuring the cognitive function using the episodic memory test. So they will ask, like the interviewer will give 10 words. They need to memorize it, and then immediately after they have the word, they need to replay the word, and 30 minutes after that. So it is immediate and delayed memory scores. For hearing aid use, we look at the question. For the first time, the respondent answered yes, that they use the hearing aids. So for the first time, once they answer that they use hearing aids, for the following waves, we will consider they use hearing aids. So this is the descriptive statistic of the analytic sample. On average, the respondent can memorize 10 words out of 20 words. And then the mean age is 82 at baseline. Most are male, 62%. Education, mostly they are from college. This is also some differences, because in the all respondents, they are mostly from primary school and high school, so the proportion of college is lower. But after we take only those with hearing aid use, and then the people graduated from college is more than, have a higher proportion than the people from primary and high school. I think education also take part of the decision of using hearing aids. And then only 14% are past smoker. They say that the 51%, almost half, having vigorous physical activity at least once a week. On average, they drink almost 3 units per week, and then the mean of the depression score is 1.14. This is 8 CESD, so the Center of Epidemiology Depression Score. So 8 is the maximal questions. And then the number of comorbidities is whether they have 6 main diseases like heart disease, hypertension, stroke, cancer, and lung diseases. And then we then modeling, so we now have those with which use hearing aids between wave 4 and wave 11. To be able to draw the line, we then collected everybody, and then we say that everybody will have hearing aids in the 0 years. So if they have it in the 4th wave, and then they will move to the 0 years. If they have it in 11 waves, and then it also moved to the 0 years. So this will be the year that they got hearing aids, and then we will predict the cognitive function before and after they use the hearing aids. And then we found that after controlling for everything else, gender, socioeconomic condition, drinking behavior, marital status, employment, and also health behavior, we found that those with those people that the cognitive decline 75% slower than before they used the hearing aids in the same person. Not only that hearing aid use associated with the slower cognitive decline, but it is also associated with higher cognitive function. So using hearing aids is correlated with 1.5 more words can be remembered of the respondents. So respondent, after they use hearing aids, they can memorize 1.5 words more. And then the other variable is female, and education, also wealth, have a correlation with the cognitive function. For the discussion is, yes, we found that we cannot deny that the cognitive will decline with the addition of age. They won't be able like increase, although we have put a lot of intervention. But at least we know now that we can slower the decline rate, so we can prevent them to go to dementia stage. And then one of the weaknesses of the longitudinal study is the attrition. So people tend to drop out because they have bad health, or they got dementia, or they die. So people who are drop out from the study usually have a poorer health condition that those in study. That's why it can be a bias in attrition. So we then simulating the result by putting the longitudinal data and then putting also survival analysis in the same time to create to eliminate the attrition bias. And after we eliminate the attrition bias, and then the significant correlation between hearing impairment between having hearing aids and the slower cognitive decline is still the same. So it's free from the attrition bias. Now we want to know that the public health efforts to increase the access to the quality of hearing healthcare may delay the onset of the cognitive decline. Our findings then support the second hypothesis that I have said, that the sensory impairment or hearing impairment lead to the cognitive impairment, because if we put intervention which improve the hearing function, it will affect the cognitive decline. The next question is how. It could be through the direct association, that with better hearing and then there is a better brain processing, and then it will then affect our cognition. It could be also indirect association, like what Tony have said, that those with hearing aids, they will have a better social function. They're no longer socially isolated, and then it will turn into a better cognitive function. Or through also physical activity, that people with hearing aid now, they are more physically active, and then they can prevent the cognitive decline. But also we cannot deny that the third variable or the common cause factor that affect both hearing and cognitive function will be still there. That's why in our next research, the one that Peter already mentioned, that we will use the UK Biobank data and then Tilda, Elsa, and share the similar one with this HRS to find this association by looking at the mediating variable between the hearing impairment and then the cognitive function, whether the hearing impairment and the cognitive function is directly associated or there is a mediation between those. So we can create an intervention, a better intervention for people with hearing impairment to prevent the dementia for them. This is the SenseCog project, and thank you.